We are live.
Good evening, everyone, and I welcome you to the iFocus online lecture series, which we are at 549, and Optics and Refraction is the module of the tonight. And we have with us our esteemed chairperson, Dr. Arvind Maurya. I've heard him speak on a lot of things. He's a great innovator and speaker. We welcome you, sir. And the speaker for the day is Dr. Prateeksha Sharma, and she is going to enlighten us about the optics of presbyopia. I think it's a very important topic because a lot of patients of today will want to know how can they be free from this. So let's learn the optics. Over to you, Dr. Prateeksha.
Thank you, ma'am. Yeah, so is my slide visible?
Yes, please go ahead.
Yeah, so I'll be talking about presbyopia, including optics. So what is presbyopia? Starting with the definition, presbyopia is a physiological and age-related loss of accommodation of the crystalline lens, resulting in a progressive inability to focus on near objects. It is caused by gradual sclerosis and loss of elasticity of the lenses, along with reduced contractility of the ciliary muscles and zonular changes, leading to decreased amplitude of accommodation. Now, coming to the expanded ophthalmic definition of the presbyopia, again, it is an age-dependent accommodative dysfunction, which is characterized by reduction in eyes accommodative amplitude, typically beginning between 40 to 45 years of age and progressing until approximately 60 years when the accommodation is virtually lost. The condition is not a refractive error per se, but a refractive consequence of the physiological lenticular aging, resulting in near point of clear vision receding farther from the eye. Now, what are the key ophthalmic points? Coming to etiopathogenesis, we'll be talking in detail about each of them. Etiopathogenesis says that lens sclerosis, decreased lens elasticity, altered lens capsule mechanics, and the diminished ciliary muscle efficiency. Onset is around 40 years, earlier in hyperopes, later in myopes. Clinical features include difficulty in reading smaller prints or performing near tasks, often described as arms too short phenomena. Correction involves plus convex lenses for the near vision. Options include bifocals, progressive, multifocals, contact lenses, or surgical connections like presby LASIK multifocal IOLs. Now, next comes the epidemiology of presbyopia. Coming to global prevalence, presbyopia is a universal age-related condition that eventually affects 100% of individuals with normal life expectancy. According to WHO, the Global Vision studies, an estimated of more than 1.8 billion people worldwide are affected by presbyopia. This is 2024 data. And among these, more than 800 million people have uncorrected or inadequate corrected presbyopia, resulting in significant visual impairment and productivity loss. Now, for the age distribution, the onset typically begins between 40 to 45 years in emetropes. The amplitude of accommodation declines from 14 diopters in the childhood to less than 2 diopters by the age of 45. Presbyopia becomes clinically significant when accommodation drops below 3 to 4 diopter, which is insufficient for 33 centimeter near work. It is complete by 50 or 60 years in most of the individual. Gender differences. Several population studies have shown earlier onset and high prevalence in females, possibly due to shorter arm length, hormonal influences, and socio-economic factors affecting the access to near correction. Geographic and environmental variations. Earlier onset is reported in tropical regions, likely due to higher ambient temperatures and UV exposure, accelerating lenticular sclerosis. Urban population may experience earlier symptoms due to greater near work demand, reading screens, and rural population often have lower access to corrective lenses, increasing functional presbyopia burden. Refractive error influence. Hyperopes develop symptoms earlier due to baseline accommodative demand. Myopes may retain near vision longer and sometimes remove their distant correction for near task. Socioeconomic impact. Sorry. The uncorrected presbyopia leads to loss of productivity, reduced quality of life, and difficulty in performing near-dependent tasks. Estimated annual global productivity loss due to uncorrected presbyopia exceeds $25 to $30 billion. Now coming to parameters, global prevalence is 1.8 billion, age of onset 40 to 45 years, complete presbyopia by 55 to 60 years, earlier onset in females, hyperopes, tropical climate. Uncorrected cases are approximate 45% and socio-economic impact is productivity and quality of life loss. Now, pathophysiology of the presbyopia, normal accommodation, Helmond's theory. In young eyes, ciliary muscle contracts and zonular tension decreases. So, lens capsule elasticity allows the lens to become more convex, increasing its refractive power by 10 to 14 diopters. Amplitude of accommodation gradually decreases from birth, which is 14 diopter, to less than 2 diopters at 45 years of age. Now, mechanisms leading to presbyopia. First is lenticular factors, primary mechanism. The lens undergoes multiple age-related changes. First is lens sclerosis. So, central lens fibers become compact and less pliable. Accumulation of insoluble proteins like alpha-crystalline crosslinks, dehydration, and reduced ionic permeability, especially sodium, potassium, and calcium channels, and increased disulfide bond formation between lens proteins. This results in loss of lens plasticity, reduced ability to change the curvature during accommodation. Second is lens capsule changes. Lens capsule thickens, particularly anteriorly with the age, increase rigidity, decrease in ability to mold the lens shape during ciliary muscle contraction. Lens geometry alteration. Lens continues to grow throughout the life. Equatorial diameter increases, anterior curvature steepens. The nucleus becomes more rigid. The cortex relatively soft. Differential elasticity leads to gradient loss. Gradient refractive index changes with age. The refractive index distribution within the lens flattens, reducing accommodative power even if the shape change occurs. Ciliary muscle and zonular changes. Ciliary muscle function. Histological and MRI studies have shown that ciliary muscle remains morphologically intact with age, but there is posterior migration of muscle due to lens thickening and scleral changes and reduced efficiency in transmitting force to the lens. Zonular alteration. The zonular fibers, they undergo biomechanical changes, decrease elasticity and increase thickness. Altered zonular tension dynamics cause insufficient transfer of accommodative force to the lens equator. Biochemical and molecular basis. So first is protein modification, oxidation, glycation and racemization of lens crystallines. Alpha crystalline chaperones activity declines, leading to aggregation and insolubilization. Oxidative stress from UV exposure and metabolic activity accelerate these changes. Lens fiber compaction reduces water content, increases refractive index mismatch, adding to stiffness. Increased calcium and reduced sodium-potassium ATPase activity impair ionic homeostasis, further promoting sclerosis. Then there are various theories which explain the presbyopia. The first and the most common is Helmond's theory, which came in 1856. Proposed mechanism was a loss of elasticity of the lens, which prevents the curvature change. It is still the most accepted and though incomplete theory. Then Shasher theory, 1992. Presbyopia due to increased equatorial diameter, leading to increased cellular tension. It's a controversial, does not fully explain the clinical finding. So, catenary theory, Duke-Elders theory, decreased capsular elasticity and ciliary body movement, partial support via imaging. Scleral rigidity theory, scleral stiffness limits ciliary body movement. It is supported by some of the biomechanical models. And then we have the multifactorial theory, which is the modern view. Combination of the lens sclerosis, capsule rigidity, ciliary insufficiency, and scleral stiffening. This is the currently accepted theory. Then we all know the amplitude of accommodation. At 10 years of age, it is approximately 14 diopters. And 60 years of age, it is less than 1 diopter, decreasing in each decade. Now, imaging and experimental evidence, MRI and Shumpert images show minimal ciliary muscle degeneration, but increased lens thickness and reduced anterior lens curvature changes. Dynamic wavefront aberrometry confirms reduced accommodative response even with intact muscle effort. Optical coherence tomography of the anterior segment demonstrate reduced lens surface mobility with aging. Early onset presbyopia. Now, what is early onset presbyopia? It refers to premature loss of accommodation, usually before 40 years of age, resulting in difficulty with near task due to reduction in accommodative amplitude earlier than the expected age. What can be the factors of early onset presbyopia? So, refractive and optical factors. First is hypermetropia, most commonly latent or uncorrected. Most common optical cause of early presbyopia. Hyperopes use part of their accommodative reserve for distant vision, leaving the less reserve for near. Even mild uncorrected hyperopia can lead to early fatigue and near blur. Clinical tip, always rule out latent hypermetropia with cycloplegic refraction. Then the second factor is myopia corrected or over minused. Myopes corrected for full distance vision lost their natural near advantage. If over minus, they need additional accommodative effort for near apparent presbyopia. Coming to systemic and metabolic causes of premature presbyopia, first and most common is diabetes, fluctuating blood glucose, osmotic lens swelling, transient refractive instability, chronic hyperglycemia leading to accelerated lens protein glycation sclerosis, and early lens rigidity. It also affects ciliary body perfusion and metabolism. Then the cardiovascular and metabolic disorders like atherosclerosis and hypertension, reduced perfusion to the ciliary body. Smoking and chronic alcohol use again can cause oxidative stress, lens protein cross-linking, and loss of elasticity. Nutritional and environmental factors, most common ultraviolet exposure. Chronic UVB exposure accelerates photooxidative damage to the lens protein, early sclerosis, especially relevant in tropical countries like India, Asia, Africa. Then occupational stress and near work, prolonged screen use and close-up tasks cause asthenopia and fatigue of ciliary muscle, unmasking early accommodative weakness. Nutritional deficiencies, so deficiency of antioxidants like vitamin C, E, carotenoids, reduce protection from oxidative stress. They may contribute to early lenticular hardening. Drug-induced pharmacological causes. So there are certain medications that can impair accommodation or alter ciliary muscle function, mimicking or accelerating presbyopia. So what are the various drugs available? First is anticholinergics, which affect the ciliary muscle. They block the parasympathetic innervation to the ciliary muscle. Example is atropine, cyclopentolate, tropicamide. Antihistamines, weak anticholinergic effect like cetirizine and chlorpheniramine. Antidepressants, antimuscarinic or serotonergic effects like amitriptyline. Then you have paroxetine. Sympathetomimetics inhibit ciliary relaxation like pseudoephedrine. Antispasmodic, anti-Parkinsonism drugs, central and peripheral anticholinergic, trihexyphenidyl. Then diuretics or thiazides may cause lenticular electrolyte imbalance like hydrochlorothiazide, which is little rare. Then another cause is ocular pathology. Premature lenticular changes, early nuclear sclerosis, lenticular thickening, or post-inflammatory changes, especially after uveitis, can cause premature presbyopia. Lens capsule fibrosis leading to reduced elasticity. Ciliary muscle dysfunction, seen in cases like uveitis, cyclitis, or degenerative ciliary body atrophy. Examples in high myopia trauma. It leads to reduced accommodative effort and responsiveness. Iatrogenic or post-surgical cases where laser vision correction may unmask presbyopia earlier, especially in latent hyperopes. Then intraocular lens implantations, monofocal IOLs remove natural accommodation, and retina scleral surgery may alter ciliary body and zonular dynamics. Genetic and hereditary factors of premature presbyopia. Some individuals have inherently low accommodative amplitude, possibly due to genetic difference in lens fiber elasticity or crystalline protein composition, familial tendency to early lenticular sclerosis, and rarely congenital anomalies of ciliary apparatus may predispose to early accommodative loss. Then the table shows the summary of the causes of the early presbyopia. So we have refractive cause. Most common is latent hypermetropia, over minused myopia. Systemic cause, diabetes, hypertension, smoking, and metabolic stress. Sorry. Environmental causes like UV exposure, prolonged near work. Nutritional causes, antioxidant deficiency, pharmacological, anticholinergic, antidepressant, antihistamines. Ocular pathology, early lens sclerosis, uveitis, post-surgery, and then we have genetic cause like familial early lenticular hardening. Coming to presbyopia in children. Now, what is the definition of presbyopia, which we have already seen that it is usually an age-related decline in accommodative amplitude, typically beginning after 40. However, presbyopia-like symptoms or true accommodative insufficiency in children is an abnormal pathological condition referred to as premature or pathological presbyopia in pediatric or young population. It indicates loss or reduction of the accommodative function well before the normal physiological age. Now, normal accommodation in children at birth is the amplitude of accommodation around 14 to 16 diopter. By 10 years, it is still 14. By 20 years, it comes down to 10. Hence, the children and young adults should have robust accommodative reserve and should not require plus addition for near birth. Therefore, any significant loss of accommodation in a child is always pathological and the underlying cause must be identified. What are the mechanisms of presbyopia in children? Presbyopia in children does not result from lenticular sclerosis as in aging. Instead, it is caused by dysfunction of any of the part of the accommodative pathway, like neurological cause, which affect the parasympathetic innervation of the ciliary muscle. It can be central in the midbrain or peripheral, like oculomotor nerve or ciliary ganglion. Common neurological etiologies include Eddy's tonic pupil, which is Holmes-Eddy syndrome, damage to the ciliary ganglion or post-ganglionic fibers. Causes are tonic, slightly sluggish pupillary action, and reduced accommodation in one or both the eyes. Common in young women, 20 to 40 years, but can appear in children also, and present as sudden near vision difficulty. Oculomotor nerve palsy. Involvement of the parasympathetic fibers, there is loss of accommodation and ptosis. It can occur post-trauma, infection, or intracranial lesion. Encephalitis, demyelinating disorder, or midbrain lesion. Affect the Edinger-Westphal nucleus, leading to loss of accommodative reflex. Then pharmacological causes. So again, the same medications. We have anticholinergics, antihistamines, which are taken in the form of decongestants, especially in kids. Then we have antidepressants, we have antispasmodics, and we have sympathomimetics. Even the topical ophthalmic atropine for myopia can temporarily mimic presbyopia. Metabolic and systemic disease, against the most common diabetes mellitus, which leads to osmotic lens changing, leading to accommodative paresis. Diabetic neuropathy, it can affect the parasympathetic fibers, loss of accommodation, but it is reversible with a good glycemic control. Then multiple sclerosis Guillain-Barré syndrome, demyelination of the parasympathetic fibers leading to impaired accommodation, usually bilateral, may fluctuate. Mitochondrial and metabolic disorders affect the high energy demand tissues like ciliary muscles. Myopathic accommodation failure, example Kearns-Sayre syndrome, progressive external ophthalmoplegia plus pigmentary retinopathy plus heart block. Congenital or developmental causes, there can be congenital absence or maldevelopment of ciliary muscles, rare congenital abnormality, which leads to absolute loss of accommodation from birth and may be associated with other anterior segment dysgenesis. High myopia or microphthalmia, altered ocular biomechanics can lead to mechanical limitation of accommodation. Post-surgical after congenital cataract surgery, aphakia, pseudophakia, loss of natural lens accommodation is inevitable if no accommodating IOL is placed. Toxic causes, organophosphate poisoning, chronic exposure paradoxically causes prolonged ciliary spasm followed by fatigue and accommodative paresis. Heavy metal toxicity with lead or mercury, neurotoxic effect on ciliary pathway. Now, this is the pathological summary. So, the causes of presbyopia in children. So, first is lens, which is rare in children if sclerosis or metabolic causes like diabetes or radiation. Then diabetic lens changes can occur. Then ciliary muscle myopathic or toxic inhibition. It could be due to cycloplegics or muscle fatigue. Ciliary nerves or ganglion, post-ganglionic parasympathetic damage like in Eddy's pupil, midbrain Edinger-Westphal nucleus, central parasympathetic dysfunction, multiple sclerosis, encephalitis. systemic, metabolic, or mitochondrial disorders, diabetes, Kearns-Sayre syndrome. Then true presbyopia, no, these are the differential diagnosis. True presbyopia occurs after 40 years of age. Accommodative spasm is intermittent, blur, pseudomyopia. Accommodative paresis is again transient due to drugs or toxins and is reversible. AD's pupil unilateral tonic reaction. Oculomotor palsy associated with ptosis and eye deviation. Aphakia, pseudophakia, post-surgical absence of accommodation. Then we have neurological mechanism is parasympathetic denervation, AD's pupil, third nerve palsy, pharmacological anticholinergic atropine histamine, systemic or metabolic cause like autonomic neuropathy, diabetes, multiple sclerosis, congenital development, ciliary muscle anomaly, anterior segment dysgenesis. Post-surgical could be aphakia, pseudophakia, congenital cataract surgery. Toxic causes like heavy metals, organophosphate, industrial exposure. Functional fatigue, overuse of accommodation, prolonged digital use. Now, how can we prevent or delay presbyopia from ophthalmological point of view? Presbyopia results in multifactorial biomechanical failure of the accommodative paresis. So we have already seen the causes as the lens itself gets sclerosed or the capsule gets hardened. So the zonules, they'll reduce the elasticity or the ciliary muscle shifts a little posterior and becomes stiffens. And ocular surface, even the ocular surface contributes to early presbyopia. So tear instability and aberrations leading to decreased dynamic focusing accuracy. Therefore, prevention focuses on slow lenticular changes, maintaining ciliary muscle efficiency, reducing oxidative and biomechanical stress. So, what can be done to prevent presbyopia in early stages? So, UV blue light protection, chronic UV exposure accelerates photo-oxidative cross-linking of the lens proteins. Use 100% UV blocking sunglasses or intraocular UV filters in blue light blocking lenses may reduce oxidative stress to the lens and retina, though the long-term proof is limited. Smoking and metabolic control. Smoking increases free radicals, accelerated lenticular changes. Tight glycemic control in diabetes delays the lens protein glycation and maintains transparency. Nutritional antioxidants, vitamin C, E, lutein, zeaxanthin, zinc, selenium help limit oxidative damage. High fruit vegetable diet like spinach, kale, citrus correlates with later onset of presbyopic symptoms. Ocular surface optimization. Chronic dry eye increases optical aberration, asthenopia, unmasking early presbyopia. Manage MGD, use lubricants, encourage blinking during near work. Visual behavior and ergonomic habits. Manage near work demand, follow 20-20 rule. Every 20 minutes, look 20 feet away for 20 seconds. Reduce continuous accommodative stress from smartphones and screens. Visual hygiene, proper illumination, 300 to 500 lux for near task. Maintain optimal working distance, 40 centimeters for reading, 60 to 70 for screens. Avoid prolonged night reading under dim light. It maximizes the pupil size. Optical aberrations are more, fatigue is more. Accommodation training. Periodic focus shift exercise, distance near alteration, maintain the ciliary muscle tone. Objective studies showed that short-term increase in amplitude of accommodation and near visual discomfort. Pharmacological and experimental approaches. So we have meiotic depth of focus drops, symptomatic delay, pilocarpine 0.4% to 1.25, 1.44%. Investigational carbachol and brimonidine improve near focus by pupil constriction and pseudo accommodation. These do not reverse aging, but can delay reading at dependence by months or years in early presbyopia. Certain lens softening agents, lipoic acid cholinester UNR844 targets disulfide bond within the lens proteins, restoring elasticity. It is in the phase 2 studies showed more modest visual acuity, near visual acuity improvement. Phase 3 results mixed developmental pause due to concept remaining promising. Cross-link inhibitors, anti-glycation. Experimental small molecules, example, amino-guanidine derivatives, aim to prevent lens protein cross-linking. Preclinical data encouraging and human application pending. Ciliary muscle tonics. Agents enhancing muscarinic activity without systemic side effects are under studies. Goal is to maintain accommodation and amplitude. Surgical and biomechanical preventive concepts. Scleral expansion or micropore techniques, early versions, anterior scleral plates, visibility or insert aim to restore ciliary efficiency by relaxing zonules. Results modest or current research exploring laser scleral microporation to improve biomechanical compliance. Some early human data show partial accommodation restoration. Corneal extended depth of focus ablations like press by LASIK can compensate functionally, postponing reading at needs to several years in pre-presbyopic patients. Early presbyopia IOLs for patient requiring lens surgery, phakic cataract, or early presbyopia with lens opacity, EDOF lenses or adjustable IOLs can provide long-term presbyopia resistance. Then coming to the target, approach and status, lens biomechanics, UNR 844 analogs and oxidative stress modulators. Status is they are phase 2 to 3 trials mixed, reformulations ongoing. Ciliary muscle elasticity, gene expression, smooth muscle metabolism studies, they are preclinical. Scleral flexibility, laser microporation, radiofrequency microchannels, early clinical feasibility. Non-invasive accommodation imaging like dynamic OCT, wavefront aberrometry, use of monitor progression, preventing on trials. All these are research frontiers of 2025 and beyond. Then patient counseling points for patients, especially for the clinical use. Depending on the lifestyle, you can advise the patient for UV protection, stop smoking, maintaining diet rich in antioxidants. For systemic health, control diabetes, hypertension, hyperlipidemia. Visual behavior includes frequent distance breaks, proper working distance lighting. Ocular health, treat dry eye, maintain tear pills. Early pharmacological options includes consider meiotic drops for temporary near vision improvement, but under supervision. And for regular exams, detect the refractive shifts or early and lenticular opacity promptly. Pharmacological treatment of presbyopia and recent advances. What FDA has improved till 2025 is pilocarpine hydrochloride 1.25%. Mechanism of action is muscarinic agonist, meiosis plus mild accommodation. It increases the depth of focus due to pinhole effect. Dosing is 1 drop once daily. Onset is 15-30 minutes. Affect 6 hours, patient to patient. Common side effects includes headache, brow ache, conjunctival hyperemia, eye irritation, blur. Label warnings includes retinal tears and detachment risk, which is although rare. Caution with night driving and in patients with retinal pathology. Then pilocarpine hydrochloride 0.4%, low dose pilocarpine in comfort-oriented vehicle. So mechanism of action is pupil modulation pinhole with low pilocarpine load. Just a minute. Dosing is 1 drop. Mechanism of action is pupil modulation with low pilocarpine load. Dosing is 1 drop. May repeat after 2-3 hours for about 8 hours. Single-use vials. Trials is near 1, near 2. Met primary key secondary endpoints. More than 3 line of near vision gain without distance loss. Common side effects is 5 to 8% installational pain and headache. Then comes the aceclidine 1.44%, which was approved in July 31, 2025. It's a pupil selective meiotic, predominantly in iris effect, minimal ciliary stimulation, near vision improvement up to 10 hours in phase 3, once daily preservative free. Regulatory status, it is FDA approved, US launched in Q4 2025. How these drops work, clinical training. So category A meiotics like pupil modulating pilocarpine 0.125 or 0.4 or aceclidine 1.44%, investigational combos carbachol, brominidine, brimonidine and delivery technology is microspray. They increase depth of focus via meiosis, accommodation contributes variably. But in emmetropic or mild emmetropic presbyope with good distance acuity, no significant ocular surface and retinal disease. So patient selection, good candidates should be selected of the age 40 to 60, early to moderate presbyopia, desire on-demand near vision for work or social tasks, normal macular periphery, open angles since we are using pilocarpine, healthy corneas, the surface should be OSD controlled and no significant night driving dependency. Now, you should be cautious or should avoid the patient having history of retinal tears detachment, lattice, high myopia with peripheral pathology, uveitis or narrow occludable angles, pseudophakia with small optic and task in dim light. Counseling. Onset duration expectations, hours, not all day in many. Possible headache or brow ache, transient dim or blur, driving at night precaution. Stop, examine urgently for if flashes, floaters, or curtain like symptoms occur. Workflow tips. Baseline refraction, mesopic pupil and retinal periphery check. You can try in the office and still reassess the near vision acuity at 30 to 60 minutes and check the distance vision acuity and contrast. For borderline responder, consider low ambient light, lightning tweaks, task lightning, and switch agent or dose schedule. What could be the adverse effect of safety pulse? Common is headache and brow ache, burning, conjunctival hyperemia, transient blur, typically mild or semi-limited. Less common and important is accommodative spasm, dim vision, night glare halos, rare retinal tear or detachment, which are flag symptoms. Then contact lenses. This has to be remembered, especially in myopes, people which use contact lenses. You have to remove them before use. Wait for 10 minutes before reinsertion. Then, what are the late stage or emerging in 2025? Pentolamine 0.75 alpha 1 alpha 2 antagonist causing dynamic meiosis via dilator relaxation, being studied alone with a low dose pilocarpine, which is Vega phase 3 program. Carbachol plus brimonidine, example Brimocol PF. Fixed combo shows extended duration versus component alone. Phase 3 data presented, regulatory planning evolving. Then aceclidine and brimonidine phase 2 insights suggest longer late hour effect with brimonidine adjunct. Pilocarpine 2% via microspray. It is positive in phase 3. Results reported and device-based microdosing under continued development. Lens softening agents like UNR 844. Early RCTs shows near vision gains, but Novartis halted US program after failing endpoints. Development status uncertain. Mechanistically appealing, targets lens biomechanics, but not approved product. So what is the scenario? If a patient wants once daily, longest reported duration and minimizing the ciliary stimulation, then we have aceclidine 1.44%. Prefer lower pilocarpine concentration with the ability to redose for longer coverage, 0.4% up to twice daily. Then early adopter, already familiar with the brand, single daily dose acceptable is 1.25% of pilocarpine. Always individualized by pupil size, lightning demand, ocular surface status, and retinal risk profile. Start one eye test dose in clinic for new miotics if the retinal status is uncertain. Add fundus periphery check if symptoms or risk factors. For night drivers, consider daytime, task-specific dosing or avoid miotics altogether. In dry eye or MGD, pre-treatment of the ocular surface to improve comfort and optic stability. Miotics can exaggerate the symptoms, so consensus and clinical practice much needed. Post-LASIK pupils may show exaggerated dysphotopsia. Trial and reassess functionally, reading speed and contrast. So the bottom line is that miotics, particularly pilocarpine 1.25%, pilocarpine 0.4%, and aceclidine 1.44% are now practical on demand. Options that extend near or intermediate function by pupil modulation, they do not reverse presbyopia. Screen carefully for retinal risk, counsel on dim light issues, set realistic duration expectation. The next wave, where the pupil modulators with longer wear, alpha blocker adjuncts, and device-based microdosing is close. Lens softening pharmacotherapy remains unproven after mixed result. Presbyopia correction with LASIK. Corneal strategies you can do with femtoexamer laser. First option is monovision or microinvision LASIK. A mechanism, distant target in the dominant eye, mild myopic target in the fellow eye of 0.75 to 1.5 diameters for micro monovision to provide functional near or intermediate vision. What are the pros? It is simple, reversible, minimal dysphotopsia from multifocality, cones, potential loss of stereopsis, contrast sensitivity at high anisometropia, neuroadaptation needed. In 2025, a systemic review reports that stereopsis and contrast sensitivity can be reduced in aspheric monovision implementations compared with some modern blended multifocal profiles. Next comes the press by LASIK multifactorial corneal ablations. So it creates corneal multifocal profile, central near, peripheral near, sometimes combined with a small anisometropic offset. Profiles you will see in literature and platforms is central presbyopia. Then we also have peripheral presbyopia, which is little less common. Outcomes is contemporary review and cohort studies show meaningful binocular range with good predictability. Hybrid asymmetric presbymax tends to outperform symmetric in range and subjective quality. Quality of vision, a 2025 systemic review found mixed effect of contrast sensitivity and stereopsis across presbyopia methods. Some reduction in symmetrical presbyopia, whereas certain hybrids profile fared better. Manage expectation and screen carefully. Then we have laser blended visions, which is Zeiss presbyond. Mechanism is planning micro anisometropia, usually less than 1.5 diopters, plus controlled induction of spherical aberration in each eye to widen the depth of focus. It enhances the binocular summation blend zone, delivered as LASIK workflow with dedicated planning or normograms. Evidence, multiple series, myopes, hyperopes, emmetropes show high rate of 20/20 distance with J5 on better near binocularity, long-term stability, minimal line loss reported in peer-reviewed data. In 2024, IGO review summarizes outcome, and 2025 report also supports safety and efficacy across refractive groups. Quality metrics. Reviews suggest that contrast sensitivity usually maintained. Stereopsis varies from unchanged to slightly reduced, improved depending on the series. Smile-based presbyopia strategies. So mechanism is smile plus micro monovision. Distance is dominant eye plus mild myopia in the fellow eye. Evidence says that early clinical studies show good binocular acuity across far intermediate near with acceptable stereopsis at 6 months. Still less mature than LASIK-based LBV or presby-LASIK. Patient selection workup and what actually changes your outcome. Great patients include 40 to 60 years, healthy corneas, healthy tear films, regular topography, realistic goals. Spectacle independence for intermediate and most near, not the teenage accommodation. Use caution and avoid from-frustic reticonus or irregulars, higher order abrasions. Significant OSD not optimized, macular diseases, large mesopic pupil in symmetric by LASIK, profiles, glare halo risk, and occupations dependent on fine stereopsis. Workflow tips include treat the ocular surface disease first, repeat case if unstable, quantify mesopic pupil, do dominance testing, monovision trial in borderline candidate, discuss neuroadaptation and potential for enhancement. What results to quote? Presbyond LBV, high likelihood of 20/20 distant, J5 near binocularly, with stability at 12 months beyond, minimal line loss, retreatment rates low to moderate depending on the pre-op treatment. Presby Max, hybrid or mono, good safety efficacy at 1 year. Several series show high satisfaction. Hybrid often edges symmetric of subjective quality. Enhancement 5 to 10% range reported in long-term series of hybrid by aspheric presby LASIK. Monovision LASIK is reliable but explicit about stereopsis or contrast sensitivity trade-offs and neuroadaptation. Consider micro offsets for balance. Smile micro monovision early data positive, tell patients evidence base is growing. Risk and visual quality. Contrast sensitivity and stereopsis more likely to dip with symmetrical multifocal corneal profiles than with LBV or hybrid implementations. Finding vary across studies, set expectation and test stereopsis pre-op. Dysphotopsia, glare halos can occur, particularly with central multifocality or large pupil. LBV micromono tends to be milder. Regression or enhancement. Plan for 5 to 10% enhancement in multifocal profiles over 5 years. Ensure adequate tissue and clear retreatment pathway. Now, what are the practical normograms notes? LBV presbyon target micro anisometropia with platform software controlling induced spherical aberrations. Keep anisometropia less than 1.5 diopters and personalize with surgeon's data via normogram tool. Presby Max, choose hybrid or asymmetric for broader range with patient-specific spherical aberrations induction and near eye target. Consider mild myopic offset in both eyes for hyperopes. Then monovision start with micro mono like 0.75 to 1.25 and accelerate only if the patient easily tolerates an isometropia on trial. What's new in 2024 and 25 and now it changes practice? Evidence consolidation on visual quality. A 2025 systemic review shows LBV and Prebimax hybrids preserves contrast sensitivity better than some older symmetrical presby-LASIK approaches. Stereopsis outcomes vary but are generally acceptable with micro and isometropia. This helps counseling versus monovision or diffractive optics. Fresh outcome reports, new 2025 data again supports Presbeyond safety efficacy across myopes, hyperopes, reinforcing it as to go to LASIK based solution for corneal presbyopia. Topography guided refinement. Surgeons increasingly combine topographic optimization for higher order abrasions with presbyopic profiles to protect quality of vision, especially in post LASIK cornea or borderline optics. Smile for presbyopia. More groups support Smile plus microvision pilots. Still not as codified at LASIK LBV, but appealing where flapless is preferred. Corneal inlays. Remember this historical context. Raindrop was withdrawn in 2018 due to haze. Inlays had dramatically warned wind, and if patients ask, clarify current limitations and long-term explant issues. So how to pick among the options? Quick chair side logic. Backups of maximal spectacle independence remains lens-based trifocals and EDOF's IOLs. So if the scenario that the patient wants good distance intermediate and a decent near like phone vision or minimal dysphotopsia, Presbeyond or Presbymax hybrid with micro and isometropia. High stereo needs, pilots, night vision, LBV micro mono or plano micro mono vision, conservative offsets, emphasizing trial and counseling. Hyperopic presbyope, LBV or central presby LASIK, consider mild myopic bias per normogram. Prior borderline contrast sensitivity, large pupil, then favor LBB. Micromono avoid strong symmetrical multifocality. Strong no flap preference, then smile plus more micromonovision with counseling that evidence base is smaller. These are depth of focus and binocular summation strategies. If you are trading a small amount of binocular perfection for range, reading microprint in dim light may still need a weak ad even when the patient are happy most of the day. Neuroadaptation matters 2 to 12 weeks. If bothersome, you can tune with enhancement. Expect very good intermediate and functional near. Full teenage near is unrealistic with corneal approaches alone. Then the final and the most commonly used is spectacle prescription for presbyopia. What is the optical basis? Presbyopia occurs when the amplitude of accommodation becomes insufficient to focus near object, typically when it falls below 3 diopters. Goal of correction is to supply positive plus lens power that replaces the lost accommodation and focuses near objects clearly on retina. Principle is that the convex or the plus lens moves the near image plane to closer to the retina, reducing the accommodative demand. So we are all familiar with this. Depending on the reading distance and the age, approximate amount of diopter which we need. This is age-based table. We can adjust plus 0.25 depending on patient's working distance and comfort. Method of prescribing, near vision glasses, simple readers, separate glass for near task only. Most commonly people used by e-metropes. Lens type could be spherical plus lenses. Advantage is large reading field, minimal abrasions. Limitation is inconvenient for alternating near and distant task. Bifocal spectacles, we have two types. Upper segment, we have two optical powers. Upper segment, lower segment. Upper segment, distance correction. Lower segment, near. Then we have common segment types. So one is the D type or the flat top type. Most common, clearly segmented boundary, and it is easy for adaptation. Round segment, aesthetic but smaller reading area. Executive or Franklin type, full width near area, ideal for accountants or engineers. Blended or invisible line, progressive, cosmetically good for mild ads. Optical nodes, ad segment position 2 mm below the central pupil, 2 mm below the pupil center to match the natural reading gaze. What are the advantages? Immediate near access, stable optical quality. Disadvantage, visible segment line, the jump effect, not ideal for prolonged computer use, intermediate distance not covered. Trifocal spectacles contain 3 zones: distance top, intermediate middle for 50 to 60, near bottom. At distribution example, distance plano, intermediate +1, near +2. Used for office professional microsurgeons needing intermediate clarity, monitor and instruments. Progressive addition lenses, varifocals or no-line bifocals. Optical design, continuous gradation of plus power from distance top, intermediate near. Designed via aspheric front surface curvature progression. Advantages: cosmetically appealing, smooth vision across all distance, good for patients with dynamic visual acuities. Then disadvantage: peripheral astigmatism, film effect in adaptation phase, requires proper fitting centration, costlier than standard bifocals, fitting parameters, accurate monofocal pupillate diameter, fitting height, frame tilt critical, and segment top usually aligned to the lower lid margins in primary case. Occupational task-specific spectacles, tailored for specific working distance for visual tasks. Like for computer users, we usually need intermediate plus near. These are the office lenses. Then for surgeons and watchmakers, we need high ad, short working distance, almost double the near lenses. For musicians and conductors, intermediate only, plano top up to 1.25 bottom. Librarian, architect, trifocals, occupational lenses, intermediate emphasis. Then prescribing principle for different refractive errors, like in case of e-metropes, first time presbyopes give only near glasses, usually 1 to 3 diopter, and depending on the age. Later progress to bifocals. Then hypermetropes need plus for both distance and near. Always fully correct distance, hypermetropia first, then calculate the ad. Often require earlier and high ad. For myopes, may read comfortably without glasses in early presbyopia. For spectacle user, prescribe bifocal progressive to avoid removing of glasses for rear. And for high myope, bifocal advantage is less, tailored based on distance treatment. Astigmatism, full cylindrical correction essential before prescribing the ad. High astigmatic ads may distort at near. Use aspheric or toric multifocal design and isometropia. Use aspheric lenses, contact lenses, or isometropic design to minimize anisoconia. Consider different ad powers if suppression or amblyopia present. Practical ophthalmic prescribing tips. Always assess working distance, surgeon versus teacher versus accountant. The working distance is very different. Check binocularity, 4 years, latent exo. Prefer slightly higher ad. ESO, slightly lower ad. If there is exo, then a little higher ad. ESO, little slower ad. Start with slightly undercorrected ad, 0.25 less for new users to improve adaptation. Adaptation period is 3 to 7 days for near only, up to 2 weeks for progressive lenses. Blue light coatings are recommended for digital workers. And consider separate computer glasses for heavy screen users, intermediate plus near. So again, this table shows for the special cases like post-LASIK emetropes, presbyopia may appear earlier, start with +1. Cataracts and pseudophakias evaluate residual refraction, use plus 2.5, near ad if monofocal. Amblyopia prescribe ad for better eye, avoid complex multifactorial optics. Presbyopia plus ocular surface disease, recommend air-coated, moisture-sealed lenses, less fatigue. The summary of the spectacle options for presbyopia. So we have near-only leaders. They have large near zone and they are cheap also, not for distance and ideal for early presbyopes. Bifocals distance plus near advantages, disadvantages image jump visible line, advantages moderate presbyope. Trifocal add near intermediate zone, disadvantage line visibility, ideal for professionals. Progressive lenses, no line, all distance. Disadvantage peripheral blur, ideal for mature presbyopes. Occupational lenses are advantage optimized for task. Disadvantage task specific only, ideal for surgeons and computer use. Thank you. That's all from my side.
Thank you so much, Dr. Prateeksha. I think that was an extremely exhaustive and a comprehensive understanding of presbyopia. We often forget that presbyopia can also happen in younger age and because of many medical pharmacotherapies as well. So thank you so much for that extremely comprehensive list. Now I would like to introduce our chairperson for the day. Professor Dr. Arvind Maurya has many credits under his name. He is the national convener AIOS Scientific Committee. He is also a member of the Adverse Event Committee, the AIOS FICO Board Executive Member. He is the chief editor of the video section AIOS Dynamic eBook, the chief research editor of IG's CRS, and he is an ophthalmologist practicing in Hyderabad, India. He was the first Indian to win the Ophthalmic Star Award at Amsterdam ESCRS 2021. He has under his name several international, national, and state level awards, including the one that he was first to receive the AIOS Senior Academic Achiever Award 2021 and 13 other Oration Awards. He is heading many projects based on AI on diabetic retinopathy, glaucoma, and myopia, and he has to his name several international as well as national publications. He's conducted 35 live deferred live surgery. He's the section editor of IJO, the editorial board member of EC Ophthalmology, WJCC, IJOVS, DOS Times, UKJOS, HJOS, and he was the Social Enterprise of the Year 2023 award holder by AIOS Ophthal. So, with this exhaustive list of credits to his name, I invite Professor Dr. Arvind Maurya to kindly give his comments about the wonderful talk that we heard from Dr. Prateeksha.
Thank you, Dr. Tanvi Haldipurkar, for the nice introduction. And thank you so very much, Dr. Prateeksha. You have covered the entire paraphernalia of the presbyopia. Now, coming to the few points which the left, so coming to first to the epidemiology. So, it occurs more common in the area, the tropical region, that is near to the equator, where there is high temperature, high humidity. So such region, there is premature presbyopia is seen as a lot of studies. And now coming to the changes. So the optical microscopy and the electron microscopy. So there are many changes visible. So number one is the degenerative changes in the elasticity of the ciliary muscle fibers. That is the microfibril, the fibril. And also in the lenticular changes, again, there is degenerative changes. Also, there is enhanced these glycation end products, especially in the nucleus part of the transparent lens. Also, there is the oxidative damage to the mitochondrial DNA as well as lipid peroxidation that leads to the presbyopia. Now coming to the pharmacological treatment. So aceclidine you covered very well. So there is one more study RX100. So there is tropicamide plus aceclidine. So there is a combination of muscarinic antagonist plus the agonist, and it is preservative free. So it has several advantages, like there is no brow ache or the headache that is seen, and loss of accommodation that is seen in the pilocarpine, the VOET 1.25%. So this is RX100, it is there. And there is a fixed dose carbachol and brimonidine. It has again advantages of 8R, because the cholinergic agonist as well as the alpha-2 adrenergic agonist. So it has advantage of, again, there is no headache, as well as it prolongs the delay of the pupillary dilatation. So, and it works for 8 hours. Very good. So that is the time when we do our office work. And now coming to the surgical treatment, you covered all the, but there is this scleral, this vis ability micro insert system that is placed via the sclera near the scleral muscle, and it improves the accommodative amplitude. So it enhances and it delays the requirement of the glasses. Number two, conductive keratoplasty. So this has advantage because it is not a laser procedure. So the radio frequency is used to radiate the mid-periphery of the cornea. What it does, it contracts the mid-peripheral collagen fibers. So there is increased curvature of the central part of the cornea. So this again means more than 50 years it works very well. Although the case series are there, studies are there, but more studies are needed. Now coming to the IOLs. So all the IOLs, the bifocal or the trifocal, or the this new geometric plus, in which the light, they have fiddled with the light, how much energy, light energy for the distant vision, the geometric, and the geometric plus, it's more light is for the near vision. But they have lot of disadvantages, like decrease color and contrast sensitivity, and depth of focus is decreases, and also halos, glare, and also dysphotopsia. Why dysphotopsia is there? Because in the high mesopic condition, all these optics, premium IOL, they have optic of 6 millimeter, but the pupil dilates up to 7.5 millimeters. So there is always 10 to 20 degree of the aphakic area, and that causes confusion over the temporal or the nasal side of the retina, leading to dysphotopsia. Halos and glare because of the refractive or diffractive zones, or because of the posterior apodization of the surface, because there are a small truncation is there in the posterior surface. So this leads to halos and glare. So there is two IOLs are there. One is LensTech and the other is Autofocus Pro, make in India. So they have large optic size of 7.5 millimeter. So that's why there is no aphakic area. So therefore there is no dysphotopsia. And they use the gradient refractive index. There are no refractive or diffractive zones, and also there is no posterior apodization of the surface. Then how they are able to correct the distance intermediate and near vision? By GRIN technology, gradient refractive index, that also decreases in presbyopia in lens as it ages. So in the superior part, the refractive index is 1.42, and gradually it improves to 1.54. So this how this ability to correct all types of vision. So this I would like to add, and I'm happy to take any question or query.
Thank you, sir. Thank you for adding that little bit which just was missing in her talk. I would like to ask that, with your, such expertise in presbyopia correction, today, if a patient comes to you and, he's not somebody who has cataract, what would be your choice of therapy for a person who says, I don't wish to wear my presbyopic glasses?
So then we have the Bausch and Lomb. If we need to do the examination, if there is no dry eye associated to it, then the Bausch and Lomb progressive and these multifocal contact lenses works very well.
That's true. I mean, the contact lens is surely a great option. I think a lot of us
So
should consider somebody who doesn't want a permanent, and we don't want to remove their lenses.
yeah.
But if at all you do, so what would your percentage of patients who want to go for a clear lens extraction for presbyopia correction versus, suggesting glasses or contact lenses?
Yes, means in my practice means 90% of the time I'm a means premium IOL practitioner. So 90%, that is a big number. So we go for the toric multifocal and all that. So yes, but they have limitation after certain point. So means 20% of the patient coming to us, they are they are asking for the clear lens extraction also because of their job.
Right. And they want a permanent solution or somebody
Yes,
who's not suitable to wear a contact lens.
yes. So many of them are into the film industry. So they want to be spectacle free. So they don't need, because they have problem with distance. They need a crystal clear distance, intermediate and near vision for their job.
Right.
Also in this media industry, again, they want this spectacle free, because they don't like a spectacle to be wear that decreases their means
Cosmesis.
cosmesis and their TRP levels. So it's their perception. So first we do a proper counseling, and we always say that it's better to wear glasses. Even I am wearing glasses. I am wearing progressive glasses. So that's what we try. And then if they are, then we ask them to go for the contact lenses, because that needs to be, we are only for few hours of the day. And then the remaining, so most of the time, 7 to 8% agrees for glasses or contact lenses. The remaining 12%, yes, we are doing contact lens, the clear lens extraction, and we are implanting trifocals or the Autofocus Pro intraocular lenses. That is the world's first polyfocal progressive IOL.
We have used several of them, sir. It's a great lens.
Yeah.
But
Yeah.
today, what would be your choice? Or rather, the question should be, how do you decide which patient would you implant an autofocus pro versus any of the trifocals versus any of the EDOFs, which are also now giving great near vision? So, how do you decide that?
Again, it depends on the profession of the patient. So first thing we ask is, what is your profession? How much of the night driving? These are all small things. How much of night work? How much of kitchen work? And how much means a stair you are going up and down, because when the glasses are there, the bifocal glasses are worn by the patient. So when then they are going up and down on the stairs, they are facing a lot of problems. So we consider all these small factors, and then we go for a particular. It's a customized approach.
Right. So, in your experience, an autofocus pro, would that give a crisp 6.6 N6, or are there some patients who you will still have to provide near glasses, or tell them beforehand that yeah, you may need a maybe +1 or a plus
Look,
0.7?
Dr. Tanvi, we all are practicing that habit. That
Right.
never means overpromise.
Absolutely.
Means in our counselors and even myself, when I am counseling any patient who wants a spectacle-free life, even the cataract patient. So we are saying them that 75% of the time of the patient doesn't require any glasses, but 25% of the patient might require some or the little presbyopic corrections.
Right. Great. I think maybe to summarize, since we've just crossed 9 o'clock.
Ma'am,
Sorry.
I
Yes.
just have
Please,
few
Dr. Pratiksha, we would
questions.
love to hear your insights. Please.
Sir, my first question and very basic question is like for high myopes, when they are early presbyope, so they say कि वो चश्मा उतारते हैं तो साफ दिखता है. Then what do you suggest? Because these myopes already have decreased accommodation. Should we prescribe presbyopia or should we ask them कि remove your glasses and then work?
Yes, both the options can be given. If they are comfortable doing the near work by removing the glasses, all my brother-in-laws, they are myopes, right? So they are very comfortable removing their glasses, and then they are comfortable. So what we need to do is lubricants, ample lubricants. Whenever we are, when the patients, they are going for a lot of near work in there, and it is the digital now, it's a digital world. So a lot of lubricants and the rule of 20-20-20, and it works very well.
Yeah, I think I'll
And
just
sir,
add a point here, Dr. Pratiksha,
Yeah.
that most myopes, if you are, so I'm a myope, so is my husband, and we both are in the presbyopic age, and the near distance becomes very close to our faces. That's something you need to remember. So even if it's a myope, even if he takes his glasses off, he really can't read at a normal distance. He would be taking things closer to his face. And if he's comfortable doing that, that's okay. But, in a social setting, it sometimes is a little weird to do that. So in those patients, we would still go ahead and ask them to maybe wear a progressive, where the intermediate would be a little less of a near ad, and that also helps them.
Progressive works very well. Progressive.
and so my second question is, what is your clinical experience with pharmacological treatment of presbyopia?
Okay, so myself being an external expert for the CDSCO DGHS Ministry of Health and Family Welfare. So I was the one who approved this POVT in India. So yes, it's working well, but only in a particular segment of the patient. A lot of patient, they are complaining of the loss of accommodation, the problem with the distance vision, and almost means 70% of the patient, they are complaining of mild or moderate kind of bro ache or headache. And in myopes, when we use some patient, they have 1 or 2%, they have the retinal complications also. So this is my uh, clinical experience, and our center was the first to use that 0. So again, the higher dose, so that is also not effective. I think 1.25 is that is suffice.
Great. So thank you so much, Dr. Pratiksha and Professor Arvind Maurya. I think we've had a lovely discussion regarding
Any
presbyopia.
questions from the audience?
Nothing seems to be on the chat screen. Can the admin let us know if there are any questions online? Probably not.
So any experience, Dr. Tanvi, of this means a small pupillary camera inlay, corneal inlay?
No, sir. So I have not personally used it. I have seen a couple of patients who have had it implanted. I think some of them do very well, but some of them don't do very well at all. I mean, it's very different in different eyes.
Patient to patient.
Yes, yes. But
More
here I
studies
just
and multi-center clinical trials are needed.
True. And I think that again is difficult because not many patients want to go for it. So that's why large data studies are also difficult to conduct. But I just wanted to add one more point. When we said that some lenses work very well in some eyes, whereas some don't, or rather some patients, like she explained, have a delayed onset of presbyopia. I think a lot of factors within the eye help them. A small pupil having a little bit of a negative asphericity, a Q value being different. So, looking at all those factors and then matching them with a good lens does kind of make some patients very happy versus somebody who may require glasses. So these things.
So, Dr. Tanvi and Dr. Prateeksha, what is your choice of IOL trifocal in patients who has already undergone the keratorefractive procedures? Because it's a tricky situation.
Absolutely.
Can have, and we are having refractive surprise. Even the King Khan had this refractive surprise.
Do you want to go and tell first, Pratiksha?
Yeah, so again, we have to like with hit and trial methods and looking at the results of the previous eye implants. I usually go for monofocal and max for EDOF, not beyond that. I do not advise them.
If it's already a myopic ablation, not a lot of the EDOFs will, or rather, depending on what the Q value of the eye is at that time or how the asphericity is, sometimes even a simple monofocal is the best one to go. But if it's a hyperopic correction, you would even do very well with a monofocal because you would have the Q value would have added anyways, and you are going to get that increased depth of focus. So I think each individual eye will have to be looked at independently, and then that decision can be made. To be honest, I have implanted trifocals in a lot of low myopic corrections, like somebody who's had a -2. Their topographies were pristine. There was nothing to say otherwise, and they have done very well. So it really depends on each eye and how do we look at.
So now there are advanced, these optical biometers are there. So there is an option that whether the patient has already undergone some this LASIK or the other keratorefractive procedure. So then they changes the intraocular formula calculation accordingly. And depth of focus is an important factor because the multifocal, we did the first world study versus the multifocal ICRL active. It's a multifocal IOL versus autofocus pro. So the depth of focus in ICRL multifocal was 1 diopter. So what does mean by depth of focus? That even if our biometry is wrong by 1 diopter, patient vision will remain within the range of 6/6. And astonishingly, you can go through that study. It's published in Clinical Ophthalmology, I think in March or April edition. The Autofocus Pro has the depth of focus between 3.5 to 5 diopter.
Wow.
So even if the biometry is wrong up to this much, and it was more in the negative side. So from 1 plus 1.5 to minus 3.5, this was the range. So just like a teenager, it has excellent depth of focus.
Great. Thank you so much for the insight, sir. And Dr. Pratiksha, thanks once again. I think with no questions in the chat box, it's safe to say that, yeah.
Thank you so very much, Dr. Tanvi, Dr. Prateeksha, CFS, Dr. Santosh Unawar, and everyone for giving me the opportunity. Thank you. Thank you so very much.
Thank you, sir. Thank you, ma'am.
Thank you.